Thank you very much. Welcome everybody to today's webinar. It's great to see a few familiar faces in the attendees list. Today we're going to be discussing making the best of your CML medical appointments, and we've got a great panel here to sort of chat through this topic. So we'll start with introductions. So I'm Charlotte, I'm the Patient Advocacy Manager at Leukaemia Care, and I will be hosting today's webinar. I'm also joined by Joanna. Joanna, would you mind introducing yourself for me?
Hi, thanks, Charlotte. Yeah, my name's Joanna Large. I'm the clinical nurse specialist for CML at King's College Hospital, where I've worked for 10, 12 years now.
Perfect, thank you very much. And Steve, please.
Hi, I'm Steve O'Brien. I'm a professor of haematology at Newcastle. I have two jobs these days. Half of it is looking after patients with all sorts of things, but particularly CML and myeloproliferative disorders. And my other half of my job is I chair one of the NICE technology appraisal committees looking at new medicines coming into the NHS.
Perfect, thank you. And Andy.
Hi, my name's Andy Deutsch. I was first diagnosed with CML back in August 2011. I went on a clinical trial which was pretty successful at controlling the disease, but had to switch drugs after 5 years. And fortunately, I'm pretty stable at the moment.
Great, thank you, Andy. It's lovely to have you here. Thank you everyone for joining us. So the aim of today is really to talk about making the best of your appointments, in terms of starting with discussing what we mean by an appointment, and then I guess moving on to how you as a patient and tips on how you can get the most out of them, but also touching on the role of COVID-19 and how that may have changed practice in this respect. I do want to say, in case you missed the slides at the beginning, we normally ask that you sort of share your questions via the chat function, which you can find with the little speech bubble either at the top or the bottom of your screen. We're also now offering the option of asking a question verbally in person if you'd like to do so. If you'll need a microphone on your device to do this, and it would be easier if you raised your hand, so I know you would like to speak, but also you can indicate you'd like to speak in the chat alternatively as well. What I'll do is I'll then press a button, you'll be invited to speak, and then feel free to direct your question at any member of the panel today. So without further ado, I was thinking a good place to start might be to talk about what we mean by an appointment. And I wondered whether I could come to you first, Steve. I was just thinking while we were chatting beforehand about what the role of an appointment for managing CML is versus how much is done behind the scenes, if you like. So how much of the care you do between appointments. I wondered if you could sort of contextualize that for us, if possible.
Sure. I guess the world has changed in the last year or two, so appointments are not what they used to be. So an appointment these days, I would say, I'm doing a clinic tomorrow. I was just looking at the list earlier today. There's 45 people on our clinic list between a few doctors. And I'd say 3/4 of those are telephone calls. I think we've got about 8 or 9 people who are expected to come to the clinic. So an appointment for most people is waiting on the phone to ring. So that's one aspect of it. You know, the idea of video calls like we're having now, it's all well and good, but the trouble is, if you've got an afternoon to get through 45 people and some people are coming and going into the clinic at different times, it's really hard to say, you know, Mrs. Smith, I will ring you at 2:45 exactly. It's just very difficult. So it's a bit like your Amazon driver arriving. We give a window and say, we'll try our best to ring you sometimes between those. So mostly it's phone calls these days. We don't do really any video calls, mainly I think because the trust is always so security conscious that, like, doing a Zoom thing to a patient kind of gets a bit frowned upon, and it's hard to schedule, etc. So mostly it's phone calls these days. I'd say 1/4 in our practice is face-to-face. And your question about, you know, how much do we do between times versus actually in the slot of consultation, I'd say maybe 5% at the most. You know, we get the occasional email saying this result's come through or that's come up, but it's usually a little package of sit down, look at the computer, work out what's going on with the patient about to appear or be phoned, and then have the conversation, write it up, letter, dispense drugs, etc. And then we're done. So I hope that answers the question, Charlotte.
Yes, I think that's a really helpful place to start with. And I wondered whether, Joanna, you had anything to add in terms of, is it the same for you in terms of when you see people, there's very little sort of work in between for each particular person?
No, it's not. And I think maybe that's just due to the difference in the roles, that the nurse specialist role is designed to be very approachable and very accessible. So patients are able to call and email us in between visits, and we completely welcome that. And that can be to do with problems with prescriptions, because unfortunately, although what we'd really like is that people are issued their new prescription at their clinic visit, and then that they get that, and then the window comes around. It, lots of times it doesn't work out that way for various different reasons, and we're a bit out of sync. But it's also to do with managing side effects, or other things that might occur, like, can you help me get a blue badge, or I'm going to have my wisdom teeth removed, or are there any other considerations? My dentist's very nervous. Can you tell them they don't need to be? I mean, it's very, very varied. So I would say that about 25% of my time is used helping patients in between their clinic visits.
Perfect, thank you. We'll come back to the sort of when you'd like people to get in touch with you later, because I think that's an important point. But it's interesting to contrast the roles there of you and Steve. Andy, I wondered whether you could come here and say a little bit about your experience of appointments, I guess, across time. Do you feel like how often you have appointments changed over the course of your, I think, 10 years you said, since you were diagnosed, and has what you talk about in those appointments changed, do you think? You're on mute.
Thanks, Charlotte. Sorry about that.
That's okay.
Yeah, definitely. When I was first diagnosed, it was by chance, and I was actually admitted to hospital. I wasn't particularly chronic. It wasn't an acute disease; it was chronic. But and I stayed there for 3 days, saw lots of people, then came out, but still lots of blood tests early on, a lot of nervousness. I didn't really know what was happening. You're in shock at that stage. And that gradually recedes. You get to learn and meet registrars and consultants, your consultant. And most importantly to me at that time were the clinical nurse specialists that I was lucky enough to have at the hospital I was in. So I got a really good chance to build up a relationship with both the consultant and the clinical nurse specialists. And then my consultations diminished to once a month, and then for some time now they've been on every 3 months, except when I had to change the drugs because of the side effects, when I had a few monthly meetings. In the early days, I would say I really didn't focus my questions very well. I was more in a listening stage, just happy that it was being treated. But now, as I've got through the process, and certainly now 10 years, I had a consultation today and it was very, very different to the first one. So asking a lot more questions, wanting to know a lot more detail, and feel that I've got the relationships I need now to have the confidence to ask those questions. It's really something really medical, and it's about my drugs and what have you. It's usually the consultant, but as Joe said, I had a query. I couldn't get travel insurance for a holiday, and the clinical nurse specialist gave me a list of 5 people to try, something as simple as that. So it definitely changes, and people need to be confident that they'll settle down and it will get better as time goes on.
That's really interesting. Steve, is that something you see in your patients as well, that change that Andy describes about focusing his questions and doing more listening at the beginning and then becoming more confident over time?
Absolutely, yeah. And everyone's different in terms of how they deal with that, how they respond to it, you know, how much information they want to know, actually, as well as their confidence, as Andy describes. But yeah, I think that's a pretty typical pattern, to the point now where, you know, a bit like Andy's describing, I've got patients that know me very well from 20 years ago, sometimes not just 10 years ago. So I know I can call them and we'll have a chat about the weather or holidays and everything else is fine. See you in X months, and not a problem at all, because they've asked all their questions years ago, and they know the warning signs if I mention something, and they know I'm straight talking. So if all's well, they're fine for the next few months. Very little reassurance required. Whereas Andy's absolutely right. You know, the first few months really, and I think it's been a problem. I might come and discuss this shortly over the last year or two. You know, the first few months of getting to know and trust your nurses and doctors and forming that relationship as a bedrock of your future care, it's more difficult than it used to be. But I agree with Andy. It takes time for people to work out how they want to approach being a patient, if you like, and dealing with this thing when maybe they've never been ill at all before in their lives. So yeah, that takes time and relationship building, as well as just, you know, confidence.
Yeah. Joanna, is that something you find important as well, is building that relationship with patients?
Oh, agreed. Absolutely crucial. You need to develop that that trust, and I think it goes both ways. You need to sort of you need to get a measure of people, and they need to get a measure of you. And although, you know, you are your authentic self within your professional role, different patients will need different things from you. They'll need their communication tailored in different ways. Some are going to require a lot more detail than you would expect to give, and some will just find a place where they're happy with a relatively low level of detail, and you know, and everything in between. But that initial feeling that there is somebody there for them, they are cared for, they are known, is really crucial to getting off on the right foot.
And would you say, I didn't want to come to COVID so early, but I think it's really important to ask this question. Would you say that's been more difficult for those who have been diagnosed during the pandemic? Have you found that more difficult to build that relationship?
A little, perhaps, and I guess it a little bit depends on the pathway that patients have entered our care in. If it's been a very incidental finding, they're otherwise well, and they haven't necessarily required the intensity of initial treatment that some patients would go through being admitted, for example, or even leukapheresis, where their sort of blood is cleaned by a machine, and they're in patients for a long time, and we can go and see them every day and really get to know them. We still are seeing, you know, newly diagnosed patients fairly recently, but a lot of what's happening now is that patients are able to have their bloods done virtually, and that's followed up by a telephone call. And that, of course, you know, it's got lots of pluses to it, but it means that you don't necessarily get that face-to-face time. On the other hand, you don't also have to sit in a waiting room for 3/4 of an hour. So, you know, there's pros and cons to both approaches. But we'd hope that we would still try to give people enough face-to-face time that they know who is looking after them.
Great, thank you. A couple of really practical questions that I thought might be useful, just in case we've got any fairly newly diagnosed people in the audience. Steve, maybe best put to you. It's more around how frequent appointments should be in terms of managing CML, and are there sort of guidelines that consultants follow in terms of how often patients should be monitored, and is monitoring the same as an appointment? How much of this is sort of written down and shared among consultants in terms of best practice?
So if I think of when, you know, someone's first diagnosed with CML, they often end up getting admitted to hospital on a Friday evening at 6 o'clock because the GP's seen a blood count and had a bit of a wobbler. They've probably had a high white blood cell count for months. And unlike other forms of leukemia, CML, by the very name of it, chronic myeloid leukemia, tends to take a long time to declare itself. And it's not usually such an emergency as, having acute myeloid leukemia, for example, where usually it's an emergency. So I think a lot of people, not really by design, but by default, end up coming into hospital. Maybe they didn't need to. Perhaps their first visit could be to a clinic, but that's just the reality of life. GP very worried, casualty doctor very worried, into haematology ward for a day or two, and then folk get started on treatment. So usually it can be hydroxycarbamide, which is an old-fashioned treatment which we don't use in any sense in the future now, but it's quite good for controlling things quickly in a day or two. But no one ever stays on that now. You go on to one of the newer tyrosine kinase inhibitors like imatinib, etc. So if you're in hospital, it might not be for more than a day or two. But actually that sort of catching of a patient who's in distress and having a chance to chat while they're in the hospital isn't a bad thing. To say, oh, you've got leukemia, we'll see you in 3 days, just means you're going to be frightened for 3 days. So that's point one, is often it's a hospital admission, getting used to talking about the diagnosis, what it means, etc. The second phase, I'd say, is the first 6 or 12 months. That's when you start your treatment. That's when you figure out whether you can tolerate it or not. That's when all these various milestones come up, and we might talk about PCR tests and all that kind of stuff. But that first 6 or 12 months, as well as building a relationship, as we discussed, is quite an important thing for doing PCR tests to make sure the treatment's working well enough. And there's loads of guidelines, and there have been for years, for healthcare professionals to read up and work out whether a certain treatment is working well enough. So that's the first 6 or 12 months. After that, most people are plain sailing, and we tend to then make the appointments maybe 3 or 4 monthly, usually no longer than 4 monthly. That's happened to be a number that's come out from some of the logistics around dispensing and COVID, but it used to be 3 monthly, but rarely less than 4 monthly. And then you're in that sort of pattern forever, really. I can't remember that I've ever discharged a patient with CML from the clinic completely. You're under the wing of haematology for a long time. So first part is, crashing into hospital with a leukemia that's frightening and unexpected. Second part is the first 6 or 12 months while you tweak things, watch out for monitoring, signals. And then the third phase, I guess, is long term, which thankfully most patients with CML get to enjoy these days with the benefits of the drugs.
And Andy mentioned how his appointments were more frequent at a certain period where his treatment wasn't working as well as he'd hoped. I mean, what's the purpose of that specifically? What would his haematologist been looking for with those more frequent appointments?
I think that there's 3 things about that, really. The first and probably the most important is how you getting on with your new treatment. All of these medicines, there's 5, maybe 6 drugs, perhaps 6 soon, for CML now. Most people are on the first drug, on imatinib, because it's very good and works fine for most people. But they all have slightly different side effect profiles. Some of them, there's a higher risk of cardiovascular problems. Some of them, you get water around your lung, a pleural effusion. Some of them upset your tummy a bit more. So if you've just switched, that's the first thing. How's it going? Are you putting up with this? Is the dose right? Do we need to reduce it for a little bit? Number 1. Number 2 is particularly looking at the blood counts to make sure they don't drop too much. That's really quite rare, though, so it's not too much of a concern. But sometimes your platelets can be a bit low, or your neutrophils, and that needs to be just watched whilst you get used to this new treatment. And then number 3, which probably takes a longer time to assess, is it working? If you switched because treatment A wasn't working very well, on treatment B, how's the PCR looking? How's the blood count responding? And that's over a longer period of time, really. So it's tolerability, hematological side effects. Is the blood count okay? And are you responding to this switch treatment?
Great, that's really helpful. Thank you. Andy, I wanted to come back to you in terms of frequency of appointments. Obviously, you've experienced a little bit of up and down over the years. How does this work for you in terms of fitting those hospital appointments into what you do day to day, work, the rest of your life, is it sometimes, does it feel too frequent to have to go to hospital every 3 months? Is it an inconvenience, I guess, is what I'm asking?
Not for me. I'm semi-retired now, so it's not such an issue. But even when I was working full time, my employers were really good. They knew once every 3 months I'd have a day working from home, or if I had to go somewhere, I'd go into the hospital first thing in the morning, at 8 o'clock when I could do my bloods, and then I'd go back again later on for the appointment. I actually, having built up the relationships, I find I think Joe referred to it, the online bit, because if everything's under control, not online, but the telephone call, easier, because you're not sitting in a waiting room for an hour, as has happened to me on a couple of occasions, and I understand the reasons why. And it is more convenient. If I've got to go into hospital for to do my bloods, which I do where I am, then that's one trip in a day. I don't really want to make a second trip. So for me, it's fine. But that's because I've got the relationship, and I know that if I did want to go and see someone, if I picked up the phone or emailed the consultant secretary, it wouldn't be a problem to go and do that. If you're newly diagnosed, I guess that's harder, and you need to make sure those relationships exist. So for me, every 3 months is fine, and I look forward to it, because I just look forward to the fact that I'm going to get a clean bill of health. That's the way I think about it. Every 3 months, as Steve says, it's rare anything's a problem. So hopefully that sums it up.
That's what thinking that's interesting. You find it reassuring rather than worrying. I think that's a nice way of looking at it.
Yeah.
We've talked a lot about an appointment, but not much about who is present at the appointment, I suppose, so far. We were talking beforehand, Andy, about how you've experienced changes in who you've seen. I wondered whether you could touch on that briefly before I sort of turn to our clinical panelists to discuss what sort of should happen, if you like. Well, who has who you've seen over the years changed every time you pop into hospital?
A little.
Mm-hmm.
So initially, I would, after the initial, as Steve described, first few days in hospital, and then the frequent checkups, which for me were every week for a month. After that, it settled down to a visit to the consultant, and the clinical nurse specialist would be there in attendance. So and she'd always come and see me first, just check everything was all right, be there when I saw the consultant, and then if I wanted to see her again, I could either pick up the phone or she'd wait, or I could wait and call her when she was free. So that worked really well. I then carried on seeing the consultants. The one thing I'd add, and it's slightly different angle, Charlotte, but initially I'd always go with my wife, because I would be a bit fazed by it, and two of us there would remember all the questions we thought about, and between us we could get through that. So I think that's quite an important point, which we might want to come to later. And then, I had the confidence after a few years and everything was fine to go on my own without any problem. When I had the side effects, which meant I had to change drugs again, my wife came along with me and gave me the reassurance. And funnily enough, a couple of questions came up during the consultation that I probably wouldn't have thought of, but she did, which is great and is reassuring. And now for the last, I don't think she's been for 3 years now. So, and I don't feel any need for that. And, it's just the way it works. It works well for me. So now it's just a phone call. And interestingly, my last 2 appointments have not been with a consultant by phone, but they've been with a senior pharmacist. And I found that fine, absolutely fine. There's no problem with my treatment, so that would be fine. And I know that if I want to speak to the consultant, I can do. But the pharmacist has been excellent, very thorough. And I feel probably, it's got, an equal understanding of all the drugs, that's for sure. And I've got some other drugs I take for other things. So it's always good to check the interaction of them and what have you. So, yeah, that's how it's progressed for me over the few months.
Great, thank you. We'll come back to the pharmacist bit in a moment, but Joanna, I wanted to ask you if you have seen a shift maybe in how many patients you see alone rather than alongside a consultant. So I think Andy describes how it changed over time throughout the course of his journey, if you like, with CML. Is that something you do more and more now, is seeing patients alone for their appointments?
Yeah, I mean, I run 2 clinics a week, which are autonomous nurse-led clinics, both for CML and for sort of kissing cousins myeloproliferative diseases. So a move towards very experienced nurses seeing, stable patients is definitely the direction that a lot of disciplines are going in, and increasingly that's including pharmacist colleagues as well, where that's appropriate and where the resources are available. But certainly, Andy, if he wants to come to King's, which I don't think he will do from Sheffield, I undoubtedly would be seeing him myself in a clinic, and I really only go to the consultant clinic these days for newly diagnosed patients or patients who are upset, or indeed the consultant themselves needs some additional support and somebody else there. But I agree, the most important person in the room, Andy, is the wife. And if I could prescribe wives on the NHS, I really would. I wouldn't mind one myself. They're extremely useful people. But having 4 ears instead of 2, or is really fantastic, especially in those early years, whether that's your wife, your sister, your friend, and being able then to have access to a specialist nurse to come back to afterwards and say, hey, we forgot to ask this, or I should have told you this and I didn't, or various other things that sometimes you don't think of at the time, but you need to kind of carry on that conversation in some way or form.
Yes, I agree. And I think we'll certainly come back to how to get the best of the appointments. And it's really interesting that it's popped up already. But just before we do that, I wanted to pick up on the pharmacist point. Steve, I think people have a perception of pharmacies in terms of community pharmacies, people who dispense medicine, but is there a slight difference between someone who's working in a hospital pharmacy and those people you see working in pharmacies, and what sort of expertise do they bring to the team, if you like?
Yeah, there's quite a big difference really, because of course the hospital pharmacists in whatever area tend to be much more specialized than community pharmacists. It's the same as having a GP and a specialist in a hospital. It's a very similar thing. So our specialist hematology pharmacists are just amazing. If I ask them about some funny drug dose or side effect, they'll either know it straight away, or they'll find the brilliant sources of evidence, the papers, and tell me in 5 minutes. And they'll also check what we do all the time. So every prescription that I put through, that we all put through, has a pharmacist checking it to make sure we haven't cocked it up and got the dose wrong, or made it not long enough, or what have you. So there's a crucial role for the pharmacist to play, even if they never came to see any patients at all. But in our hospital, again, that's evolving over time. So we very much have a pharmacist with us now who's critical to the care of our CML patients. And it tends to be a little bit, as Andy has described, our pharmacist has a little flock of patients, if you like, that she looks after, who are perhaps a bit more straightforward and been on the go for a long time. So often the appointment is, rinse and repeat. How's it going? It's fine. Have you run out of medication? Yes. Do you need some more? Yes. Press a few buttons on the computer, or with our software, press hundreds of buttons on the computer. And then, the drug goes out. And actually a lot of, you asked at the beginning, how much work is there between consults? I'd say of the work that does come through, generally for, it's our secretaries, our pharmacists, us lot in emails and phone calls. It's, my pills haven't arrived, or someone's forgotten to write a prescription for this because they were on the phone over there. And there's a lot of logistics around dispensing, prescribing, and delivery these days, your Amazon parcel equivalent, if you like, which I think mean that pharmacists are fantastically well placed to do a lot of that stuff. And we're hopefully in the next 6 to 12 months going to actually increase that contribution. We'll get another half of pharmacists, hopefully, and they can prescribe, troubleshoot lots of problems, and they transform the logistics of the service. And there's a lot of that, a lot of this is getting medicines to people in a timely way, etc. So we didn't used to do that not so many years ago, but we certainly do it now, and it's increasing, I think.
I think it depends a lot on, on the resources that teams, have available in terms of funding. So it sounds a lot of crossover between roles. So I would also prescribe the TKIs, adjust the doses, prescribe adjunctive medications, and largely manage that pathway for most of the patients, liaising with the home care delivery companies and being the port of call. And it's very much easier for the stable patients to have somebody that they can be in touch with more easily to do that. It's just one less person to go through. But I think certainly expanding the roles of specialist nursing staff and specialist pharmacists will be the way that we deal with chronic diseases across the board going forwards.
Yeah, and it certainly sounds like it's working for you, Andy, in terms of what Steve described essentially is you're talking about the medication most times you go now because of how long you've been living with the illness. Is that fair?
Yeah, it is. And I mean, the pharmacist even did my every year I do a Q risk assessment. She did that for me today. So, I was very comfortable with the appointment I have. So very good.
That's great to know.
Charlotte, it might just be worth clarifying what a Q risk assessment is, because maybe not everyone on the call knows that. Just very quickly for folks, there's 14 things that go into this formula. There's a website for it. And basically you get a number out of the other end, which tells you or predicts, based on lots of other events, what your cardiovascular risk is over the next 10 years. And that's kind of relevant because some of the medicines that we use in CML perhaps increase that cardiovascular risk. So we're just kind of weighing up the benefits, the pros and cons. Sorry to chip in.
No, I think that's really helpful. Thank you. It's one of those things that you assume when you're living in the haematology world, I guess. Thank you. That's really helpful. Oh, Joanna, before we sort of go on to sort of maybe a few more tips on having a good appointment, in some conditions, people tend to see a GP a bit more these days. Do you have much interaction with CML patients' GPs, or do they tend not to be so involved?
Some, yes, Charlotte, and that's largely, I was nicely segued because it is largely to do with managing cardiovascular risks. And some of that will be to do with the medications we use, but some of it will just be that we know people over time, and because we are seeing them on a regular basis in a way that primary care are unable to, we pick up, rises in blood pressure, rises in cholesterol, in blood sugar before they were, just because of frequency of monitoring. So working with GPs to establish them on a solid monitoring pathway in primary care, where they are the experts in blood pressure monitoring, is quite a lot of accounts for quite a lot of the communication we'd have with GPs. We might pick up things like thyroid problems. If somebody comes in and they tell you repeatedly they're tired, it's not always hematological in source, and so you might pick something up additionally and need the GP's help, because they'd be the most appropriate person to take the reins there.
So if someone was experiencing these issues, then you'd send them back to the GP for further assessment?
It very much depends. We tend to, I guess, a little bit, because we know patients well, and we want to do our best for them. So if they had a really nasty rash, and I could find a dermatologist for them, I'd go the extra mile and try to get it sorted while they were with us. But if they're going to telephone me and say I've got a nasty rash, and I don't imagine that it's got anything to do with CML or with their medications, then I'd probably advise them to see their GP, and I might then liaise with the GP to put forward that it probably isn't the fault of the TKI in this case, or maybe it is. But it largely depends on the symptom and what we can do, what with the person, and what's most convenient and most appropriate.
Great, thank you. Andy, have you had much experience with sort of GPs being involved with your care at all?
Yes. I've had a few other conditions, some of which may have been brought on by the initial drug I was on. They may not have been. No one really knows. I've had bouts of different things. I think it's fair to say the GP would normally defer anything they thought was a haematological thing to the haematology team at the hospital. Other things they just get on and tackle with, but always the communication is always pretty good. So when I speak to my consultant or the pharmacist, I'll always say, I've just recently had a batch of gout, which is boring to everyone, I'm sure, but it's important for me that I share that with the pharmacist. So, and it was good because I could talk through with her what the GP said, and it was a bit reassuring, really. She said, "Yeah, no, that's exactly, you're doing exactly the right thing, and don't complicate it." So, for other things they'll deal with, but they tend to defer the haematology things back to the consultant.
Great, thank you. I wanted to move on slightly to sort of talking about the actual appointment itself, and you've talked already about your wife and how useful it was to you to have her there, Andy. Just wondering, sort of prior to an appointment, during the time when you felt it was helpful to have her along, not that it isn't always helpful, but you know what I mean. During that period where she particularly came along with you, did you ever prepare for an appointment in advance? Did you ever sort of sit down, have a conversation, either alone or with her, to sort of think about exactly what you wanted to ask at all?
Yeah, always. Probably not so much very, very early on, because I really didn't know what I was asking. But after probably 6 months in, we'd have a list of questions. We'd probably sit down a couple of days beforehand, not, just maybe over dinner or something, and it would come up and we'd say, right, what are we going to ask in a couple of days, and jot some notes down. And then when we were traveling to the appointment, we'd probably go back over it and say, what about that? We've missed that out. So I think it's really useful not to leave it until the day of the appointment. Get your mind thinking about it a few days before, and then you've got time to distill some stuff and then refresh it on the day of the appointment. And I always make a list. I can't remember it all, so I always make a list and methodically go through that list and try where I can to write the answers down. So initially I was probably a bit, maybe I felt I was a bit rushed by the appointment. So I thought, I've only got a certain amount of time. So I wasn't maybe as thorough as I should have been about asking. But now I'm a lot more confident, and, I'll just say, look, stop, I didn't understand that, or give me a minute to write it all down. And then I've got a record of it. So that's the other thing. I think, so preparing is important. I think that probably covers it, Charlotte, from that perspective.
Oh, that's really helpful. Thank you. Joanna, I wanted to pick up on something Andy said there. He said at the beginning he didn't know what to ask. How do you, as a nurse, sort of encourage people to think about what they should ask, if you like, when, especially sort of during the early few months when they're chatting to you?
That's an interesting question. I haven't thought about it quite like that before. I guess what we're doing, I'm always really conscious that when we have a new patient, regardless of their background, their educational attainment, that most people don't know that their blood is made in their bones and then they go overnight to talking about chromosomes and tyrosine kinase inhibitors, and it is like learning a new language. And so it doesn't surprise me to hear that, you know, after some years Andy's become fluent and well, or proficient, and I think, you know, that's the same for anyone. I guess what we're doing is, you know, laying out the things that we're monitoring and hoping that the patient infers what questions would come from that. But it's a really interesting reflection point for me to prime people for what might be useful for them to ask. I mean, we try to encourage people to declare their side effects, talk through what side effects are possible, so that they feel that that channel is really open to discuss, and they, you know, don't suffer in silence and therefore maybe not take their tablets because they fear the side effects. So we want to promote, you know, good adherence. So, you know, taking all your tablets all of the time. And we can't do that if people don't understand what the side effects might be. But no, so it's a really interesting question, and one I might put some thought into about, you know, what questions might you ask, and what are we monitoring, and how are those related? So we talk about what BCR-ABL actually is, what that means, what other terms for it might mean, when we're going to monitor it, what would constitute a good outcome, what the milestones we're looking for are. And I guess we are just inferring that people are taking that on board. But that's a really good point. We might do a bit of work around that.
Thank you. Yeah, something I've also thought about, because we do try and make these, so you've been newly diagnosed, here's what you need to know, but you never really know what people are thinking at that moment in time. Steve, is there anything you wanted to add on that point?
I've got a fairly simple take on this, and I can't help but be influenced by my experience of many years of working with NICE. And there's two things that would matter to me if I got a leukemia diagnosis, and I think matter to most people. And that's quantity of life and quality of life. You know, so people are sometimes even frightened to ask at the beginning, you know, I've got leukemia, am I going to die from this fairly soon, or is it going to be okay? And sometimes people dance around that question, and it takes them a little while to work up the courage to do that, because people associate leukemia with, you know, dying quite quickly historically, unfortunately, and that's not the case, of course, with CML. So again, you know, that takes a little bit of gentle conversation to work out what people want to know and when they want to know it. But, you know, is my life expectancy going to be compromised by this condition is obviously critically important to people, but they may not want to ask that straight away. And then quality of life. So, you know, are these drugs going to mess up my ability to do what I want to do? Is the leukemia going to mess up my ability to do my hobbies or do my job or go out walking or whatever I like to do? And again, figuring that out in general, that most of these medicines are associated with a good quality of life, takes time. But that would be my emphasis in the first few meetings with a patient. You know, let's just establish that you're probably going to be okay here. Treatments are good, probably going to be okay with quality of life because they're usually well tolerated. And then the things that Andy and Joanna have mentioned, that the more technical details, if you like, you know, what does a certain level of PCR at a certain time mean? People get into that mostly over time and work it out. And there's some very helpful books that you guys and other people produce, and loads of videos and things, you know, from the right source that will talk you through that. So I think I personally tend to focus on the things that would worry me if I had a leukemia diagnosis, and then the technical things come with time, I think.
Great. And this got me thinking while I was listening to the two answers there. Is there, you mentioned there was stuff you didn't ask early on. Was there something you wish you'd asked earlier? And if so, why do you wish you'd asked it earlier?
This is going to sound very easy in hindsight. And whether I could have got to that point, I don't know. But when I first went on to I was on a trial, a clinical trial, and there were some side effects associated with that. And it was very thoroughly explained to me, and I have no qualms, criticism about that at all. But as it progressed, I was getting some side effects, but they weren't obvious. And they did occur, and I was picking them up, but I didn't associate it with the drug that I was taking. And I wish I'd done more at the time to find out about that. I do ask myself from time to time, but it's an easy thing to have hindsight, isn't it? And think how easy would that have been to be able to do. But it's the only thing I can think of, Charlotte, really.
No,
as Steve says, and Joe says, you learn the language, you learn what the blood tests are, BSCR-ABL, you learn that in time when it becomes important to you. So I think Steve's words were very sensible.
I appreciate I put you on the spot with that one. It's something that occurred to me a moment ago. Joanna, I think Andy makes a good point there about side effects that you don't realize are related to TKI. Is it helpful if people talk about everything they're experiencing, even if they haven't made that connection yet? Do you try and encourage them to sort of talk around these things a bit? Sorry, I can't hear Joanna. Is that just me?
No.
No, good.
Maybe your headset's come out, Joanna. We've lost your voice. Not working.
We still can't hear you. Maybe Steve, you could jump in there while we wait for Joanna to see if we can fix it. Did you have any thoughts on that question, in terms of getting people to talk around side effects?
Ask me the question again, Charlotte.
So I was just saying how Andy said that he didn't associate the side effects with his TKIs to start with, and is that something that you see commonly, and do you try and encourage people to talk around more generally about how they feel?
I always blame drugs for everything, because I've been around a long time and I've seen drugs cause all sorts of strange things that are not printed on the side of the box, sort of thing. I mean, there are really predictable side effects with the TKIs, but I've had some patients with really tricky and often occasionally really quite debilitating symptoms, in younger, fitter people. That's not something you might necessarily expect with one of these classes of drugs, with tyrosine kinase inhibitors. But, I've ended up trying to switch to something else to see if it was that, or have a treatment holiday, stop for 2 to 4 weeks and see if all the symptoms go away. So I think you can let folk know that there are several symptoms that are really very common, and you should expect in many ways. But people sometimes come up with slightly more offbeat things where you're not really sure whether it's, the drug or not. And as I say, I'm always suspicious that it is the drug. And I think that's the right approach, because we don't know everything about all these drugs, or any drugs for that matter. And I think being cautious and circumspect about side effects that are a bit unusual is always a good thing to do.
So the message to everyone is to talk about everything you might be feeling, just in case, it's related.
Yeah, and again, that we've touched on it a little bit. We might talk about some more. That's a bit trickier on the phone. There's a couple of my patients, I can sort of tell how they are when I go into the waiting room and say, Mrs. Bloggs, and she gets up and walks towards the consulting room. I can sort of see if she's got a spring in her step, or if she's struggling a bit with her hip this week. There's subtle things like that you don't always get on the phone. And I think people often feel it's an abbreviated conversation on the phone. They don't feel they can chat as much maybe as looking someone in the eye in a consulting room. So all the more important then, if you are having a phone consultation, to say, I'm not sure if it's significant, but I've got this pain in my hips, and maybe it's just old age, but maybe could it be the medicine or something? So yeah, I'd encourage folk on the call today, if they're not sure whether something is a side effect of the drug, don't just write it off, mention it. And sometimes it's clear, sometimes it's less clear, but it's certainly worth mentioning, especially in a phone call.
Great, thank you. Sorry, I thought I was on mute for a moment there.
Joanna's
Technical.
trying to say, can we hear? I can literally.
Let's
We
see.
can't hear you, Joanna. I'm not. There's a.
We can't hear you, I'm afraid. I don't know what's happened. Maybe you could, if you like, try logging off and logging back in and see if that helps, and we can continue in the meantime without you. It's up to you. Hopefully it'll resolve itself shortly. Be a shame to lose you this late in the day. So I wanted to, just while we see if we can get Joanna to, in case anybody can't read the message, Joanna wanted to say that mood was a key thing, and not to be afraid to speak out about that. Is that something you concur, Steve?
I'm just going off mute. Yes, absolutely. It's an awful lot to cope with, getting a new diagnosis of leukemia. It's obviously a major life event. And, you might think you're fine, and I don't need to talk about this, I'll just take it in my stride. But that diagnosis, and I've seen it many times, it may not catch up with you straight away, but it sometimes does later, and you feel low and you're worried about things and you just need someone to chat to. So I think Joanne's absolutely right to emphasize that. And again, it concerns me a little bit in the modern way of doing things. If it's a 5-minute phone call saying, yeah, how are you doing? I'll get you some more tablets, see you in 3 months. There's not the same opportunity. So it takes a bit of courage, perhaps on the phone, to say, hang on, can I just stop and talk about this because it's on my mind? But again, I'd encourage you to do so.
Andy, I'm interested in your perspective on this. How have phone consultations been for you? Is it something you had before the pandemic?
No, I haven't had any phone calls before. As I say, I think whilst I'm stable, I probably prefer it. Although half of me thinks it's probably nice just to catch up with everyone once every now and again and re-establish those relationships face to face. So that's something I'm looking forward to doing. I think Steve's right. Just going back to the mood thing, I think Steve's absolutely right. Your emotions are all over the place to start with. I don't think you can think straight. You're all up and down you literally minute to minute. I think there is a period, it probably happens to most of us, where you've been reassured and everything's great, and then you suddenly think, what if I'm the one in the million that it doesn't work for, or what have you. So it does get to it. I've been very lucky. I've had good support around me from family and friends. My employers have been excellent. And I would say, Charlotte, the support groups you run are very good as well, that Leukemia Care run. They're a great sounding board for people, and, to get other people's feelings of it. So you've got to somehow find someone to talk to. It doesn't have to be a medical person, but it is important, and it will hit you at some point.
Yeah, I think peer-to-peer support's got a really important role to play in sort of making the best of the time between the appointments, which isn't strictly what we're here to talk about, but you can't really sort of avoid that period of time when you're discussing sort of the discrete moments between. Joanna, you're back with us. We still can't hear you. I'm so sorry. I don't know what's going on. We'll carry on, and if we can't hear you, yes, feel free to contribute to the discussion through the chat, and we'll make it work. Absolutely.
Joanna, you could reenact that scene in Love Actually and hold boards up.
Oh yeah. Any way you can participate is absolutely fine. It's lovely to have you still. Thanks for coming back. I was going to also take a quick look at that comment. Exactly how I feel. Fine. Okay, this is an interesting perspective that someone's posted in the chat. They feel that they're fine normally, but they also worry about being the one person, and I'm sure it's more than one, the treatment does not work for. Steve, any thoughts on that at all?
I think that's a fair worry. I mean, we emphasize, and it's great to be able to do this. I mean, I've been involved with CML for 25, 30 years now, and in the 90s, I certainly wasn't able to say this, but one of the first thing I say to people with CML when they come and see me is, you're going to be okay. Now, that doesn't mean everyone's going to be okay, because very rarely still CML can go wrong and be difficult and requires much stronger treatments, but that's really very rare. And I think that my approach in terms of combating anxiety and uncertainty is facts and information. Not everyone works that way, but I certainly do. So the more accurate info I know about what prognosis is like, response rates, etc., the more I personally would be reassured if I was facing a serious illness. I think that's what I try and offer, is the facts, some good or mostly good, occasionally bad. But you can't help, I don't think, feeling that, okay, most people are going to be fine, but what if I'm not fine? And the only way I can see to combat that is reassurance and information.
I think you can hear me now, can't
You're
you?
back,
We can.
Yeah.
Fantastic.
Just for anyone else, this little thing, if you lean on it, you can turn yourself off. But there we go. You live and learn. No, I'd echo what Stephen says. I'm always very circumspect about offering enormous amounts of reassurance, and that's that not always helpful for as we understand the vast majority of people who will have a very, very good prognosis and be quite unproblematic from our perspective. I'm sure it doesn't feel like that at the other end, but there are roughly about half of people imatinib isn't going to be the answer, and they're going to need to go on to a second generation treatment. And when you've been told that it's okay, this is, I hear all sorts of things like, we were told if we were going to have any cancer, this would be the best one to have, which is a slightly off color thing to say, I would think. But as a big center, we often get the patients who have I don't want to say failed, it's not personal, but who haven't responded to treatment as they wish. And it does feel like a double whammy for them to have been told this is very treatable and then find that they're not the ones that it works for. And then obviously of that, there'll be a tiny little group of people for whom it is still a very dangerous disease and will need to go forward to bone marrow transplant. And if you've had extremely reassuring conversations up front, and then that reassurance has sort of got a little bit less and has been a bit more qualified, and then has turned into, something really frightening, you do kind of lose trust. And I think it's sort of, better to sit on the good news until you can be really sure that those people are in that category. And I'm sure Steve and other doctors and nurses in CML would agree with that. And sometimes that's just how we are as humans, that we find someone in distress and we want to give them the good news before we really truly understand all of the prognosis.
Absolutely. That sounds like it sounds as if that first appointment is key for managing expectations as well, just sort of coming full circle to the reason why we're here today. I guess it's in terms of what you share at that first appointment, you do need to sort of temper expectations and of how it's going to go, given how positive experience most people have with CML. Just I'm thinking about how this also links to decision making. I think one example of a decision, I guess, that doctors and patients with CML have to make is if they're changing treatments. And I think that's it seems on face value to me that becomes a different kind of appointment than if there is a decision to be made. Maybe come to you first, Andy. You've had experience of sort of changing treatments here. If you were expecting some sort of decision to be made at an appointment, do you come at the appointment differently, if you like?
Yeah, I mean, it was pretty obvious to me that something had to change. Not necessarily the drug, but the way I was taking it, or something. And I wasn't au fait enough to know exactly what. My side effects were pretty severe. So again, it was obvious something had to happen. I didn't rush it. And the control from the drug had been very good. So all my results were very good. And the consultant I was with at the time said, we need to decide what the best way forward is. So at that point, I actually did something I'd never done before, which was to start to read some information online, but I was very careful about what I went to read. So it was stuff from the NHS, it was from the drug company information. There's a lot of stuff out there that I wouldn't go anywhere near. Leukemia care stuff is very good. And I was trying to get as much information I could about the prescriptive drugs and the side effects of those drugs, so that I could have a meaningful conversation with my consultant, given my age and what had just happened to me, as to what the best course of action was. I think the decision took 4 to 6 weeks. I can't exactly remember, but it was several weeks. And he was very good. He didn't rush me, and it was a joint decision that we made together. But he didn't force me down one route. But when I'd made that decision, he said, I think that's exactly the right thing to do, with his help. And I think if I'd made the wrong decision, he would have said, are you sure that's what you want to do? You've got to be clear and all the rest of it. So all I'd say to everyone is take your time, get as much information as you can, but only what you can absorb and what you're comfortable with, and make sure it's from the right places. Don't just go to anywhere, talk to the professionals about it.
It sounds as though you were empowered to be a part of that decision, which is really good to hear. And Steve, maybe that's you could share from the opposite side of the table, if you like, how, if you have a suspicion that you need to make some sort of change, some sort of decision, how do you make sure the patient feels as though they're a part of that process?
I think a couple of things to say. First of all, is I think that sort of discussion really benefits from a face-to-face. I don't think I ever want to have that discussion on the phone, because it just isn't fair. Maybe the last phone conversation you had 3 months ago is everything's fine. And then you ring up and say, oh, it's not so good now. That's quite difficult on the phone, whereas it might be less difficult face to face. So I think that's the first thing to say. I ask people to come and have a chat with me in person if there's something trickier, more complex to talk about. The second benefit of that is you can look at the computer together. A lot of these decisions about whether to change or not are sometimes they're based on side effects, intolerance. Sometimes they're based on the disease not responding as well, and actually being sat together looking at the same computer screen, and all systems are different, but I can plot a graph, a picture of the PCR, for example, different numbers, and then we can say, oh well, it went up there a bit, and this was a year ago and we did this and it came down and it's such and such. I think it really helps people, to understand why a possible consideration of switching is on the cards. And you can't do that on the phone very easily. You could with the technology, but it's just not that practical in the NHS still at the moment. So I think seeing stuff together, information, results, is helpful. And I think the third thing I'd say is these decisions are almost always slow. They are rarely urgent requirements to change treatment. And sometimes a PCR has gone up a little bit and you don't know if it's just blipped up and it's going to come down, or if it's going to go up and up. And those two scenarios have different implications for treatment. So being able to chat face to face, saying, oh, I'm thinking I might do this, but on balance, we'll sit and wait for a while. And it could be in the next 3 months or so, we have to do something. Taking time, both clinically makes sense because you don't want to, make the wrong decision. And emotionally and psychologically, I think makes sense as well, because it gives folk a chance to, think it through a little bit, maybe Google a bit more, have a chat with family about what the right thing to do is. And then maybe the next visit or the one after that is the point where you say, okay, we watched this, it's not really going the right way. On balance, weighing up risk and benefit, probably we should make a change now. So face-to-face is good. Looking at information together is good. And taking your time is usually okay, and actually ends up with it being a more sensible and more accepted decision.
Do you find some of your patients worry if you invite them into face-to-face then as a result of that?
You don't want to come and see the professor in the clinic, especially from another hospital, which is, as Joanna was saying, in bigger hospitals, you tend to refer trickier patients from colleagues in the region. So, I don't think there's any way of avoiding that person's going to be a little bit worried, A, to come to the specialist centre, and B, to see a senior doctor to have a chat about something. So that's just the way it is. Those situations are a bit worrying. Obviously, I try and reassure people. And I think once you've had that conversation, they realise it's not a frightening immediate emergency, then that will provide some reassurance. So if I am going to bring somebody in, and I've seen some numbers that concern me, I'll normally ring them and say, look, we need to talk about this. Will you come in a week or two face to face? But, no, don't panic. We just need to chat about things and share the information.
Yeah, absolutely. And Joanna, we did actually talk about phone appointments while you were absent briefly. I wondered if you wanted to add anything on the role of phone appointments. So Steve's talked about how it's not helpful for him in terms of explaining decision making. Is there any particular time where it's good for you, bad for you, phone in particular?
It very much depends on the individual and their needs, but it also sort of depends a lot upon how we manage the logistics of it. So I think it's very helpful if the patients had been able to, and it does take a little bit of effort on the patient's part as well, to have their bloods, including their BCR-ABL, taken a couple of weeks beforehand, so that when we have that telephone consultation, we can discuss the results, and we get a bit of closure there on the day. A lot of what happens is that patients don't have their bloods taken at all because they're not coming in to the hospital to see someone physically, and then a lot of the telephone consultation is about how we're going to organize those bloods, and planning the logistics for the next meeting, and that's something that's happened over COVID, and we haven't, hopefully other centres have got it right, we haven't quite got it right here, just largely because of the very, very varied availability of blood taking for molecular testing in the regions, and how that's managed, and it's very, very bitty and very individualized. So we're getting into the swing of it, but again, it depends very much on how someone is. So in the past, when someone would come in with a bit of a chesty cough, you sort of, would have a listen to their chest and maybe have a chest x-ray, and we give them some antibiotics, and we could sort of solve it there on the day. But obviously, if it's a telephone, it's going to be, advised to go to the GP and then follow that up afterwards. And, both models are workable. I suspect if you were coming from the South Coast and it was saving you a trip up to Camberwell, which is a very lovely place, by the way, everyone should come to Camberwell, but not to come to King's, just for a visit, you might be pretty happy not to come up, although I really miss patients selfishly. I know it's not all about me, but I really miss them.
I'm sure you do. I think you make a really interesting point about monitoring. It's something I hear a lot from patients. If the blood test goes wrong and then they have an appointment, but they can't actually talk about anything in the appointment, I think a lot of people tell me how frustrating that is, and I'm sure it is. Andy, is that something you have experience of, or do you tend to find that you've been lucky in that the smooth process of blood test appointment works well for you?
Yeah, no, it works fine. I do mine on the day, and I patiently wait 3 months for the next one, but that's only because it's been stable for ages. When in the early days and when I was switching, it would be every month, so you get the result very quickly. So it works well for me. Yeah, it's fine.
Great. It must be reassuring when it all works smoothly, much less of a headache anyway.
Yeah,
we've had a question from someone in the chat. Thank you to this person. I think you're probably best placed to answer this, Andy, if you don't mind. Someone's just asked for a bit of advice in that first 6 months where they're sort of worrying about the treatment working. And did you have any thoughts to share with this particular person about how to sort of cope with that first 6 months?
I would say trust your consultant. You don't know very much about what's going on. Talk to your nurses if you've got any concerns. They'll be there to help, I'm sure. But your consultant's in by far the best place to tell you what actually is happening. I couldn't add any more to that, really, Charlotte.
I think that's really good advice. Thank you. Steve, is there anything you'd add to the advice for patients in that first 6 months at all?
We've touched on it a little bit before. I think getting into the swing of things, both in terms of tolerability of treatment and how well it's working, is what happens in the first 6 to 12 months. Without going into lots of details, there's been masses of research done about what should your PCR level be at certain time points, and it's in all these guidelines, and you can probably find them on the internet if you go and dig around. So nominally your PCR level might start at 80 or 100%. That's the ratio of the leukemia to the normal gene. And at certain time points, it should be less than 10. At certain time points, it should be less than 1, so that it's kind of on a downward trend. Those are guidelines. Not everyone necessarily performs in that way, and it's not the end of the world if you don't hit those milestones. But there's been lots of work done on that. So there's a mixture of, are you tolerating this treatment well? Is it causing problems for you? And secondly, are you kind of getting through those milestones that many of the guidelines would suggest are kind of useful monitoring standards?
Charlotte, can I come back in on something there?
Yeah, of course.
The one thing I should add is, initially when I first started on the drug I was on initially, I did get lots of side effects. None of them were severe, but they were annoying, uncomfortable, and I was told they'll ease over time, and they did. But they took several months to ease, probably 6 months plus, I think. So I would say, as long as you can live with them, persevere if the drug's doing what it should be doing.
Great, thank you. Joanna, anything you want to add for this particular person who's fairly new to the party, if you like?
Yeah, this is sort of a bit more than a side effects question, isn't it? If the hemoglobin is being really impaired by the dasatinib, I would say, yeah, give it a bit of time, but that probably needs your consultant to really think about that. It's a little bit complex to go into here, but you'd want to understand why that was. But in terms of how you come to terms with things in the first 6 months, I would say reach out, don't suffer by it alone, make sure that there's people you can talk to. If you don't have, people in your immediate circle who are, really able to, I guess, finding a really good counsellor, and hopefully your hospital can provide that. It's really important, because we, people like me and Steve, we try to get to know people really well and try to offer holistic care, but at the end of the day we're sort of rather geared towards fixing things, and I know that friends and family, they tend to want to just tell you it's all going to be okay and be strong and we can get through this, and all of those things are completely valid, but sometimes you need a sort of third space where you can go with your darker thoughts and your anxieties, and have someone work through them with you in a different sort of constructive way. So if you are really struggling and you're finding yourself sort of hiding your tears and feeling quite anxious in lots of ways, or maybe being more snappy than normal with friends and family, or finding it hard to concentrate, they're all flags that you probably need a little bit of extra help. And that would be the case with anyone with a new diagnosis that has come out of the blue. So I'd say, stick in there, use your team for help. That if you need extra help, really do seek it.
Perfect, thank you. I noticed there were a few newly diagnosed people popping up in the chat. Wanted to say we do have a few other webinars that we've done across 2021 on CML. We've covered treatments, we've covered living well more generally, and a lot more side effects chat in that particular talk. So if I will try to find them and post them in the chat before the end, or my colleague will before the end of the webinar, so you can access those as well. I hope you find those useful as you sort of come to terms with things. Steve, very, very quickly, someone's asked if you could go over what the Q risk assessment was again, and if that's something a consultant normally does, or whether a patient does it, because a website was mentioned. I think that might have confused them slightly.
I am just putting it out there now. So there should be a link just gone out on the chat.
Thank you.
There's a Q risk 3 now. It's the 3rd iteration of this thing. And if you follow that link, you can go and play with it yourself. You may not have all the information to put in there. So if you don't know your lipids, for example, your cholesterol, HDL ratio, that kind of stuff, you're missing a bit, but you don't need all of it. So it's quite, I've done it occasionally just to face up to my mortality, put all the numbers in, press the button and see how risky you are or not. So you can do it yourself. You've got most of the information because you'll know it. And yeah, it's a helpful, it's not absolutely correct, of course, but it's pretty reliable, and GPs do this a lot these days. And that's kind of why, to pick up on something we were saying before, I tend to defer to my GP colleagues about cardiovascular risk and management of that, because they're better at it than I am. But they will use this tool very frequently. There's a thing called the Framingham score, which is a US-based one. They're all kind of similar. Masses of research gone into this. And it just helps give you an idea or some perspective on risk and benefit. So if you are, I'm 57, so if I had high blood pressure and terrible cholesterol and a history of heart disease and was a heavy smoker, blah, 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 would I really want to go on to nilotinib, for example, where there's a little bit of concern about cardiovascular risk, likewise ponatinib? Or would I maybe take my chances with bosutinib or dasatinib? So it's not the last word in assessing cardiovascular risk, and you'll see there's no field on that link that says, what's the risk associated with the drug here. So it's not an absolute guide as to what to do, but when you're weighing up switching medicines and there's a cardiovascular risk concern, it just helps give a little bit more objective evidence to inform that decision.
Perfect, thank you. I hope that's helpful to the person asking that particular question. Just to sort of come back slightly to some of the things we plan to discuss. One very practical question, Steve. Is recording of appointments allowed, and is it something that you'd be comfortable with as a doctor? Recording?
I've never been asked that. So is it allowed? I don't see why not. I think as a courtesy, and maybe there's some data protection law around that, which I don't know well enough. If you're on the phone to someone, you record them without them knowing, that's probably discourteous. And secondly, there might be some data protection question around that. I don't know. But if someone said to me, I'm not sure I'm going to remember all of this stuff, do you mind if I record it? I'd be absolutely fine with that. But I think it'd just be a courtesy to mention it. But I've never had anyone ask me that, but it's quite a good thing to do. A long time ago, we used to, I don't quite know why, it should have got better with the technological age, but it didn't. But I remember there was a phase when we first had a diagnostic discussion with somebody. We'd put a tape into a tape recorder and record the conversation and give them the tape afterwards. That seemed to have gone away, but it should be easier now with your iPhone. So why not, leave the iPhone on the desk, press record your consult, just as a courtesy, mention it, and go away and listen to it back later. Then you might pick up on other details that are not there. We should be much better at that, actually, because, if we had video calls, this one's being recorded. Why couldn't we record consultations so that people can just scratch their heads a little bit later and revisit some of the things they're uncertain about? But it's not happened to me at all so far, I must say.
Joanna, have you got any experience of that?
No, lots of people take notes, which is really valid. I can imagine there probably is some sort of data protection, or maybe people might want to avoid that just in case things don't pan out the way they've said and they get sued. I imagine the trust lawyers might want to consider that long and hard. But I would be absolutely happy as that. I don't think we're likely to say anything, too contentious, and whatever works for people. But then again, it's completely, as Steve said, it's just about courtesy, and sometimes making notes and clarifying what those notes mean, is really helpful as well, and easier to use later in a way. But yeah, I wouldn't personally have a problem, but I suspect there's some lawyers somewhere in the trust who might want to give it a good long think over.
I'm sure there is. There usually is with these things. Andy, is it something you've had experience of trying out, or do you tend to prefer notes yourself?
I'm probably a bit old-fashioned. I just take notes. Never really thought about it, I have to say. But just don't be afraid to slow the consultation down if necessary, whether it be face-to-face or by phone, to give yourself time to take the notes.
Yeah, the key is to get what you need from it, I suppose.
Yeah,
absolutely.
Charlotte, just something to chip in as a hope rather than an expectation. I think millions of us have downloaded the NHS app in the last year or two. I did it mainly so I could go and see a gig and show my COVID pass. That's the only thing. But when I've fiddled around with it, it's got my vaccinations from years ago in there and all sorts of stuff.
Yeah. I
hope one day we might have, our patients' blood results in there or their PCRs. I can see it coming.
I think there is a I forgot what it's called, but there is something where people can manage that, but they have to upload them themselves into it. I don't.
Yeah, there is. I've come across that.
Yeah.
But the NHS app might do that for us in a while. So in terms of and having information, Andy, you got something up your sleeve?
Yeah, well, I've done it recently. Like you, I had it for the COVID vaccine status stuff, and then asked the GP for some information, and they said it should be on your app. So I had to get the GP I had to do a special form for the GP.
Okay.
And that all got turned around very quickly. And I can see all my blood results.
Oh, I get you.
On my NHS app.
It's the future.
I'm not sure I understand them all when I look at them that way, but they all are all there.
So can you see your PCR results on there, Andy?
I'll have to go log on and have a look.
Well, I'm just curious.
I might try and do it as we're talking.
That's great if you can.
Yeah, it would smooth the whole process over slightly, I suppose.
I want to know what gig Steve went to.
Yes.
Dare I confess, I went to see Sophie Ellis-Bextor, who's actually quite cool.
Oh, yes, I like her. Kitchen Disco, really good on BBC Sounds.
On the same bill was Rick Astley.
Yeah! No one's judging you.
Not at all. But he did get tapping my foot. He was
I bet. Singing along with your lighter. I think so. Is that helpful, Andy, using that app? Do you find it helpful?
It is for some things, definitely. If I look at, I've just logged on, I've got 310 consultations and events.
Wow.
But I've got
too much information.
Exactly. But if I look at test results, it gives me my last 6 months test results.
That's good.
And it's got pathology, electrolytes, biochemistry. I'd have to go into them to have a look, but I think it's got my leukemia results on there.
Maybe that's going to help us out. I mean, the adoption of that has increased massively last year because of the virus. So maybe that will be an unintended benefit for us all, is to have more access to results. So watch this space.
Yeah,
I think it is really a problem. There's very often a lot of what we do is asking administrators to chase up results from local hospitals, because some hospitals, their policy is not to share results with patients, whereas I'm happy to print them off or email them to patients straight away. And some people want to keep really comprehensive notes. I completely understand that. And I'm always amazed that, other hospitals won't do it. So I have to ask someone to go and chase them to get them out. And,
me too.
And drives me a bit mad, actually. So once all these apps